And thank you everyone for inviting me for these presentations. Do you hear me all well and do you see the slides? Is it working quite well? It's working, or I guess it is.
Yes, it is. I'm sorry.
Okay, thank you.
Everything's fine.
I'm just about that. Okay, so thank you. I'm happy to be here around. Perhaps I'm probably the only one which is not an expert in hepatitis C, but I will try to, nevertheless, to speak about surveillance and make some links with hepatitis C, which is, of course, also with an issue of do we have enough data on that things, and we have seen that maybe not. Why do we need data and for which questions? And I would like just to open my presentations with these slides, just to make a little bit funny observations we had a couple of weeks ago, where some people were asking, is fondue the cause of our epidemics of COVID in Switzerland? And I show you these pictures also because the journalist is coming from Belgium, and this Belgian journalist was asking, is fondue the cause of the epidemics of COVID in Switzerland? It's interesting because in Belgium, this is one of the only countries in Europe where they have more cases than us, so they should take care about before hurting guilty people about that. But I find interesting this question that, do we need data to address these questions? And I think there is two questions we have to separate. There is an epidemiology questions, which is fondue a source of contagions, or, and this is more a surveillance questions, do we have cases which are recorded to be linked to fondue intake, and do we need to make some recommendations about that? And I think this is important to make separations between the epidemiology questions and the surveillance questions, which is that we need informations to make decisions, and this is just an open remarks before my presentations. For these presentations, I will discuss what is public health surveillance, giving a short definitions of that. I will mention, of course, that we need data, and actually that we have more and more data. I will also make links to previous presentations. You have seen, for example, the presentations with this data from Zurich, which is impressive. We have more data, but as has been shown before, they do not speak by themselves more than small data. We have big data now, but it's not so easy to make them speak. And I will finish my presentation that how can we go toward evidence database public health and make some proposal about that. Just let's go to the definitions of what is public health surveillance. And I think in one sentence, this is about counting people. And I like this address of former Director General Li Zhongwong, who said that to make people count, we first need to be able to count people. And I think this is the spirit of surveillance. A more classical definition, this is the one by the Center of Disease Control, which is surveillance is the ongoing and systematic, which is a key aspect of surveillance, that we have to have data over a long period of times, repeatedly, so ongoing and systematic, that it has to be using the same methods across times, for examples, of collections, analysis, and interpretation. This is not only the collections of data. And what is really important, that this is closely integrated to the timely disseminations of this data to those who need these informations to make decisions. In a short nutshell, we can say that surveillance is to provide information useful for decisions and actions in public health. What is key is that to understand that surveillance is not only providing data and analyzing them, but it's really to make them available to the people who need that data about them. Key also is to make a distinction, I think, between surveillance and research. And if you think to what we are living now with the COVID, I think that we have gone through the systems where many researchers have made lots of analysis, lots of data regarding COVID. They have made some public health research, so we have developed our knowledge of the COVID, but it takes more time to develop some surveillance systems for decisions and actions. And what we need for, and what is surveillance, is using this data, gathering information, and which help us making decisions and actions. This is not directly exactly the same things and producing knowledge, which is more a scientific endeavor. And I think it's worthwhile making a distinction between both these activities. So We need data to assess the burden of disease, to design and evaluate public health policy, and to produce information useful for decisions. I will not go back to data on hepatitis. As I've told you, I'm not an expert in these fields, but it seems that we have some data. Dr. Vici has shown us some nice data across the times from hepatitis, and based on the website of the Federal Office of Public Health, you can find this information about hepatitis B. So we have some information about the burden, about the incidence, the same for hepatitis C. And so we have some information. We have some data also on hepatitis worldwide. Here I give you a map, and we have seen also other maps by my colleagues previously during these afternoons, but we can have an idea of country where the burden of hepatitis is bigger than other countries, and where there is much work to do, and where the work is more advanced if we want to prevent and reduce the burden of hepatitis. If we compare, for example, to informations we have on chronic disease worldwide, I think for hepatitis it's not so bad. We have also seen that we lack data on several aspects. I will come to that in the last of the things. What is new now in surveillance is that we have more and more data. This is all the fields of big data. And in particular, we have some health-related data, which are medical administrative data or data from digital trace, from internet, social media. For the medical administrative data, we have seen the nice examples from these colleagues working with data from Zurich to assess the mortality of people with hepatitis C. This is typically data which can be used to improve the surveillance of things about that. We have also different types not related to health, which can be used indirectly also for surveillance. And I give you one example that we have now, which is a map of France, where you can see here, it was before the confinement and after the lockdown, during the period of lockdown. And this is data from mobile phone movement. So they track the movement of mobile phone. And as you can see, in red area, this is the people from Paris moving across France during this period. And where it goes down, when it becomes yellow, you get much less movement of the people in France about that. It's new data. If you make links to infections, it can help you understand the epidemiology of some infectious disease in that case. So COVID is changing a little bit the landscapes. What is important to understand that we have a change in the way we do surveillance, because we go from design data to organic data, and I will just briefly explain what I mean by that. So the classical process for surveillance is to identify the health problems, define and collect data, typically a finite amount of data, analyze data to address the problems. A classical example is cancer registries, which is worked that way. What is very interesting is that these data are designed for what you want to measure. It's tailored for your problems. And you get some information on their validity, their reliability, and completeness, or its lack. So when you have some information from this data, you can know what is the quality, what you can do with this information, and what you cannot do. What is not so good is that sometimes timeliness is poor. The scopes can be limited. In many areas, we don't have data on all the things, and it can be a very high cost of the data. What we have now with big data at the health age is that we have all types of data collected from multiple sources, but we don't know exactly what we'll do with this data. We analyze this data to identify some problems and address problems. We analyze some patterns in the data. One big advantage is this is a timeliness of this data. Sometimes a representativeness. You can have data on the whole populations at a relatively low cost. It depends on the data, of course, but this is usually secondary use of data. So the cost efficiency of using this data can be very high. What is more problematic that we're dealing with organic data, which are not tailored for your problems. The quality sometimes of the data can be poor or unknown. The selectivity, in the sense that the people who are into these data sets are not so clear where they come from, what is the source populations. And you've got issue of privacy, access, and how to use these data. This is one of the challenges. We have this kind of data, but this is moving about that. This type of data is also interesting in the field of hepatitis C. I just show you one interest of that by the company AbbVie. This drug company was interested to using big data to better understand the epidemiology. So it's really a current, a current era to use this data, to better use this data to get information from hepatitis C. I think that one key issue that even with this type of data, they do not speak by themselves. This is perhaps one big, issue we have this type of data, that contrary to what's imagined, that it is not enough to get data. You still have to work with them to make them speak. And I can give the examples here. I like this idea that you can use these data which are not so good, which are wrong. For example, in that case, you can use another type of data which are also wrong. If you put them together, it doesn't mean that you have bigger data, but they are not automatically better to have some informations. What is key to keep in mind that even with the access to this data, it's not so easy to get information from them. And I've listened to with great interest the presentations by Fred Lachman about this data in Zurich, because she has shown us very finely that it's not so easy to make this data from the hospital, to make them speak. It requires lots of take care about making this data more smart, to be sure that what we measure is what we measure, and it's lots of work. It's not automatic. It's bigger data, so you can have more information, but you get to work on that to make them speak. What is also a challenge that what has changed very much in the field, that it's much more easy to make some complex analyses, or even relatively simple, but to make analyses. And nowadays, what we see that with the same type of data, you've got researchers who are making some analyses, the media, you've got also comments on the social media, and hopefully some people in the surveillance fields are also using this data to get information for that. But when you want to make decisions, you get to account of these different sources of data, which make more complex, a little bit more complex, I think, the fields, to some extent, the field of decisions. I think we experience that, especially with the COVID now. If you think about how research is working now, where they are using sometimes media to make some link about, or to give some information on some new results, when you have to take decisions on that, you have to count on all these informations to take decisions, which is not so easy. And this is what we have been called infodemics. We have to some extent too much information, and we have to deal with how to handle this amount of information. So, and this would be my last slides. If we want to move toward evidence and database public health, I'm convinced that surveillance is at the heart of this movement. And key, as I've shown, that surveillance is transforming data and informations which are useful for decisions. I think we have to separate, or at least to make some distinctions between surveillance and research. We have more and more big data, but as I've shown, and as we've seen also the previous presentations, they do not speak by themselves. We still have to work with them and to make them more clear, to make them speak. I think we need to strengthen surveillance systems, but also not only to get more data, of course, but also to train and to increase our culture in surveillance. And I think of both data scientists and stakeholders. So on the one hand, data scientists, epidemiologists have to give more strength to surveillance, and also authorities, public health authorities, have also to be trained and to better understand what we can do and what we cannot do with the data and how to use it. And this would be my final presentation. I thank you for interest, and I'm open to any questions about that.